We're going to begin with this video lecture, part 2 of the depression notes. You won't find it divided up within the notes in this way. I'm just doing it as we move through the video lecture just to make it a little more convenient for you to watch segments of it. So hopefully this helps a little bit. And as we begin for today, we have moved through the discovery, basically, of various types of antidepressants. And now we're going to talk a little bit more specifically about treatment development. And there have been incredible changes as we've moved through the past couple of decades and a little bit more. And so obviously, I think it's obvious, because the first suspect in terms of the cause of depression happened to be monoamines. The first real course of treatment began with monoamine oxidase inhibitors. Now remember that monoamine oxidase is the enzyme that breaks down monoamines in the synapse. And so if we inhibit that enzyme, we limit the amount of breakdown, with the idea being that there's going to be more of the monoamine we're talking about available to activate receptors in nearby neurons. So MAOIs is the acronym that I'll be using. So the first one that was really utilized at all was something called iproniazid. And actually it was first used to treat TB. And this is the way so many different drugs are actually discovered in terms of their treatment possibilities. This particular MAOI was not thought to have anything to do in terms of being useful for treatment of depression. It was used to treat tuberculosis. And in this case, it blocks monoamine oxidase in the cytoplasm of a neuron. So not extracellularly, but intracellularly. And this is the one that if you are on it or you know somebody who's on not just necessarily this one MAOI, but anyone, they call it like a cheese effect. If there is not enough monoamine oxidase available in the cell, the amine tyramine, which is found in cheese and some other foods, builds up to dangerous levels and basically can increase blood pressure, things like that. So one is kind of advised not to eat too much of certain types of foods. I know one of them was a while ago, bananas. Don't eat bananas. No bananas if you're going to take an MAOI. Turns out that the biggest problem is in the banana peel. And I don't know about you, but that's the part I don't eat. So anyway, there are better choices in most cases, but there are times where, the patient has to, end up taking this particular medication or a drug class. Second drug class, tricyclic antidepressants. Now, the first one that was kind of utilized and discovered for this was imipramine. And it was first used as an anti-schizophrenic drug. Again, we're seeing where you have something that's used for something else, and then there are kind of things that are found out about it while these other patients are taking it. Doesn't like either way of those, so anyway. And Tricyclic antidepressants block the reuptake of both norepinephrine and serotonin. And it increases the stimulation of those postsynaptic cells. Either way, tricyclic antidepressants are safer than monoamine oxidase inhibitors, in part because you don't have the danger of a buildup of the tyramine. Then along came lithium. Lithium is a metallic ion, and again, this was a serendipitous finding. Okay, this is in the 1950s. Doctors, scientists took the urine of patients with mania and mixed it with lithium, like lithium salts, and it was injected into guinea pigs along with a control group that just was injected with the lithium. And you guys all know about how you need that for a good experimental design. And there were no group differences. All were calmed but went off their food. They did not want to eat. And so it was inferred they were nauseated. I put this in here because this is how it was reported. And I always wonder about things that probably takes way too much of my time up, but how did they know they were nauseated exactly? A lot of rodents don't even have the capacity to vomit, but you know how you feel nauseous, you can describe that, but a guinea pig can't. So I assume that they used the word nauseated because they stopped eating normally, and it was really an inference. Anyway, just a little aside. This lithium should sound a little bit familiar to you because it is still used for bipolar disorder. Fourth, serotonin selective reuptake inhibitors. This should definitely sound familiar to you. We see them, these advertised again on commercials on TV very frequently. And it's one that most people are going to kind of connect to the treatment of depression. Prozac is the big name, right? That's really fluoxetine. And SSRIs, before we even say what they do, which is kind of embedded in their names, have a different structure than tricyclics. So we already have this structural difference, biochemically speaking, and they selectively block serotonin reuptake because of their characteristics, the SSRIs. And so think again, go back to how we talked about how we clear neurotransmitter molecules from a synapse. One of two ways. Let them get up on their little elevators or transporters and be taken back up into the cell from whence they came, or be broken down in the synapse with an enzyme that's specific to that particular molecule. So obviously, SSRIs work to block those little transporters or those little elevators. I like to picture them as little elevators. And if they're blocked, can't get in here, serotonin, can't get in here. You have to hang out outside in the synapse. Picture yourself waiting to get on an elevator and the doors close, you can't get in. It stops and it's packed full of people, and so you can't get in, especially now, having been in hospitals a number of times in recent weeks. It's limited to very few people who can actually get on an elevator at the same time at a hospital. So that way, what's happening? It's like you're spending more time out in the hallway waiting. The serotonin molecules are spending more time out in the synapse. And if they're out there hanging out, it's likely that they might actually interact with the receptor on the synaptic cell, the postsynaptic neuron, and thus being able to influence their firing. Okay, so these are effective for many people. Unfortunately, these drugs, especially the early ones, and even still many to this day, have side effects that are very possible and not uncommon at all. And they include headache, anorexia, sexual dysfunction, and among others. And so just thinking about the time delay in the symptom relief by SSRIs, you can imagine many people go off them because before they're feeling any better, before their depression is being relieved at all, they're experiencing all of these negative side effects. It's possible that these negative side effects will dissipate with time, and it takes some time to get to the point where these antidepressants are actually changing the symptomology of the depression. Many people aren't willing to try to wait it out. And it's understandable. That's why very often you have poor compliance. Okay, and I mentioned ECT before and talked a little bit about some of the early experiences of ECT, which are now much better. First, it was used as a treatment for schizophrenia. Once again, a treatment for one disorder ends up being useful for another one. It's used for patients now who have clinical depression and who have not responded well to any drug therapy, or if they are suicidal or delusional, okay? And that can happen in serious clinical depression, delusions. And it is much more controlled, as I mentioned before, and it seems to be particularly helpful for the depressed elderly patients. Prolonging remission in depressed elderly is a study, PRIDE, and I want to mention that out because now, you know, acronyms take on all different kinds of meanings depending on the societal, you know, influence. And this study compared a strategy of treating depression without ECT to including ECT. And they used unilateral, just one side, ultra brief, very brief impulses of electrical current. And that minimizes the cognitive side effects that can result from less controlled electroconvulsive therapy. And 62% of this group that had the ECT combined with the rest of the strategy met criteria for remission from their clinical depression. This is really important. And I know it can help. It's not something that you want to do as a first option. And I want to really emphasize that. However, I remember I was an adjunct years ago at Niagara University for a little bit. And I had a student who was talking to me about her grandfather and how he was really seriously depressed, had lost so much weight that they were worried that, you know, he was going to die from malnutrition. They were unable to keep up his nutritional needs, and he was not responding to anything. And the student talked with me and asked what I thought. And this is a hard position sometimes to be in, because I could share kind of what I thought, and what I probably would do if it were my grandfather, but I certainly can't tell somebody else to do it. So I gave her more information and talked about how it was so much less dangerous. And people weren't having, some of the side effects. And that if it were that or suicide, in my mind, it is definitely worth careful consideration. And the story is that they ended up getting her grandfather in and getting electroconvulsive shock therapy. And he improved. He improved enough to be home. He improved enough to be more engaged in life. He gained some weight back. And so for this particular patient, it was definitely the right choice. The one thing, some of the side effects that remain still is there can be some memory loss about what was happening just before the treatments and for a little bit of time after the treatment. But most people who have undergone this feel that it's kind of worth the trade-off. So that is a little tidbit about ECT. Alteration of sleep patterns. Now, it's interesting because it has been found that many, if not most, I'm always cautious with that, depressed people enter REM within 45 minutes and their body temperature is already rising. Now, you shouldn't technically be entering REM stage sleep that early, and your body temperature should still be down. Your body temperature should be going down as you're going to sleep, and that is one of the indicators of good sleep. And so one of the strategies that developed from finding these details about sleep and temperature in the nocturnal cycle was try shifting the sleep phase a little at a time. And one way they did that was to keep the patient awake all night long. And wouldn't want to be that patient. If I get to sleep, I want to stay asleep because sleep doesn't come easily. But the other thing is reduce REM sleep. Now, we have to have REM sleep, but to try to shift the phase and try to regulate an individual who's showing this unusual alteration of sleep patterns, it is thought that if you do that, that you might get into a more regular rhythm. This has been met with different results, as you might expect. And in this case, lots of times, as soon as you saw by the brain waves of the sleeping patient that they were going into REM, you wake them up, okay? And so then they go back to sleep and you watch when they enter REM again, you wake them up. So therefore, you're really reducing the amount of time that patient is in REM sleep. That's kind of the strategy behind this and the rationale for it. And as I said, it's been met with some success, probably not the most effective means, but something to know about and something to think about. Next, light therapy. And my guess is that many of you already know about light therapy. You can easily go online and learn how to build a light box. You can buy light boxes. And what does this have to do with anything? Well, very often the depression can be seasonally induced. In cold climates, more northern climates where you might have less sunshine, longer periods of darkness, shorter periods of daylight, the patients actually exhibit a change in the duration of nocturnal melatonin. Pretty sure you've heard of that, secretion between winter and summer. So it's in that time frame. Think about the darkest days that we have in this area, okay? The longest days where it's dark. There's a place in the hypothalamus, again, yay, hypothalamus, you do so much work, thank you. A nucleus called the suprachiasmatic nucleus. And it's kind of above the eyes, the optic tracts and such. And these neurons actually are thought to mediate the pathogenesis of winter depression or seasonal affective disorder. So the idea then is to try to bring brighter lights in. And that's what I was talking about with the light box. And the thought is try to expose yourself to very bright lights. They need to be like 2,500 lux for an hour before sunrise and after sunset. Basically giving you a longer day in terms of sunlight exposure. I put a little blurb in here about how the idea of seasonal mood changes dates back to the dawn of medicine, really. And I described here how scholars as far back as Hippocrates and others have talked about and described this kind of melancholy that occurred mainly in autumn and mania in summer. Frederick Cook, and some of you may have studied him in a history course, was an explorer and a physician. Good guy to have along if you're on one of those exploration trips that were incredibly challenging back in the time of his life. He accompanied the Arctic expedition of Robert H. Peary. Now, Arctic expedition challenge, not a lot of light. And Cook noted the effect of light on the voyagers and the Eskimo population. And he described a syndrome that looks just like what we're describing today in many of our cases of clinical depression, and particularly seasonal affective disorder. So this is something that was observed a long time ago, and as this blurb says, even 400 BC. That's a while back. Last, in terms of this segment of the notes, is transcranial magnetic stimulation. I have a link here for you. I'm trying to decide whether to bother opening it or not. It takes so much time sometimes to do that. Yeah. I think I'll hold off just because I want to move through this. Please stop and take a moment, please, to open this link. You can stop this video lecture, open the link, take a few minutes to look at it, read it, see the pictures. Again, I look hard to find certain links that take you to pages that are meaningful for what we're talking about, but not overly complex, so that everybody can benefit from it. But transcranial magnetic stimulation is, instead of using electrical current, essentially, you're using magnetic field. And it is safer than ECT. It seems to have fewer negative side effects or adverse side effects, and it seems to be very effective with many patients who were absolutely resistant to any other types of medications or treatments. And by resistant, I mean their depression was resistant. Their depression was not handled. I personally know an individual who was a younger person who had struggled with really serious depression and anxiety for years and had been on various medications, you name it, cocktails of medications, including some of those that I've listed above, and was even prescribed medical marijuana to try to help her. That failed as well. And again, medical marijuana may be very useful in some cases of anxiety. In other cases, it actually increases anxiety. And with depression, I've already noted earlier that for some people, there's a link between cannabis use and depression. So one needs to be thoughtful about whether or not they should try to utilize this as a treatment strategy for depression or anxiety. Anyway, this individual had gone through all of these, and finally they said, okay, let's do TMS, transcranial magnetic stimulation. And except for a headache that would come and go while she was having like 6 weeks of treatments, she had no other adverse side effects, and she is feeling much better now. This was the one thing that seemed to reduce her depression specifically. So I believe that this treatment holds much promise, and I'm kind of watching to see scientific reports on exactly where it is going. So just pay attention to that as a new possibility, okay? Now, I want to go over the current pharmacological treatments, generally speaking. And these are the ones that are, and actually almost in order of their use. As we get to the bottom, maybe it switches up a little bit, but I included the names of many of the commonly used drugs in each category here for you. So you can easily look them up. You can kind of know that if somebody's saying paroxetine, they mean Paxil. If somebody's saying fluoxetine, they mean Prozac, so on and so forth. And there are links embedded in here that you can go to actually look up these particular drugs. But the most commonly first choice for treating clinical depression still remains SSRIs. And you will see that very frequently. Next tends to be serotonin norepinephrine reuptake inhibitors, SNRIs. And so essentially, these inhibitors work the same way as SSRIs, but they also inhibit the uptake of norepinephrine. For some people, this works off. Cymbalta is under here. If you notice, you've probably heard Cymbalta. You've probably heard of Effexor. Those are the same things as duloxetine and venlafaxine. One of the potential problems with SNRIs is that we know that norepinephrine is one of the transmitters that is important in the sympathetic nervous system response. So let's just think for a minute. So if you know those basics, you don't have to memorize so much. If you know that, and it's inhibiting the reuptake of norepinephrine, so there's more norepinephrine out there, there is a potential for anxiety due to that sympathetic nervous system stimulation. Face it, when your sympathetic nervous system is activated, you're not, and it's really activated, you're not like totally relaxed. You're not like, yeah, nothing to worry too much about now. In fact, I'm just like hanging out. Just, yeah, very calm. No, sympathetic nervous system activation means you're like, right? We've all felt that. We all have felt it. It's something common to each one of us as a human being. So that is one thing that is a drawback for some patients. Then we come down to tricyclic antidepressants. That includes things like Elavil, Anafranil, and these, again, if look back into the previous section, if you want to review what this class of drug actually does. But once again, this is less preferable in most cases to either of the previous classes or treatments. Down further, we see the monoamine oxidase inhibitors, and I discussed already the problems with that. If nothing else works, and if this works, well, then you live with it and you utilize it, and you're just aware of the fact that you might have some incident where you end up with elevated blood pressure to the point that it is extremely dangerous. In fact, very often a physician, if they prescribe this, will also give the patient some special pills. I'm not even going to worry about telling you the names or anything because I don't want you to get sidetracked here. You can look it up, I'm sure, if you're that interested, or I'm happy to talk with you about it. But these are like emergency, it's like an emergency kit for high blood pressure until you get to the emergency room and you tell them what you're on, and then they take it from there. So is this going to be like your first choice? Probably not. If it's the only thing that works well, then it's one of those cost-benefit analysis situations. Now we're moving on to a couple of things that are generally more recent and are more popular now, and have definitely changed the way medications are prescribed to the clinically depressed. The atypical agents work in different ways. One most common that you will see used in these types of depression situation, and a couple of others I'll mention in a minute. Bupropion. Hate saying that. I'd much rather say Wellbutrin. Wellbutrin has taken on a fair amount of popularity in treating depression, but also seems to be effective in relieving the hypersensitivity of the nerves in those with fibromyalgia. So sometimes this is prescribed to somebody who has fibromyalgia. I know this for a fact. And it is generally quite effective. And if you think about it, if you have fibromyalgia, it can be completely debilitating. And it can come when you least expect it, but it doesn't leave, all right? And it interferes in everything you do. Does that not lead to depression even if you don't have primary depression? So Wellbutrin has kind of like a double-edged good effect in cases like this. So I wanted to make sure I brought that out and just mentioned atypical agents. So if you can kind of know a couple of those, that's a good thing. There are add-on drugs that have become increasingly popular or more available. The one that comes to mind, and mostly because you're seeing it on TV commercials, again, it's advertised very frequently now, is Rexulti. And here is its kind of official name. And it is actually an atypical antipsychotic. In fact, it is a dopamine D2 receptor partial agonist. And essentially, it has been described as a serotonin and dopamine activity modulator. So generally, this is used now as an add-on to one of the drugs mentioned above or indicated above, when that particular drug on its own is not actually completely or satisfactorily controlling the depressive symptoms. And adding this on can actually give you that extra little boost that balances out. So I wanted to make sure that you're aware that this is now becoming a more common type of strategy. Definitely one, and again, this is my opinion. Sometimes I can't help but give my opinion. And that I would personally, if I were taking an SSRI or something and it wasn't satisfactorily working, before I go to tricyclics, or definitely before I went to monoamine oxidase inhibitors, I would try an add-on like Rexulti. And just kind of my take on it. Everybody has their own opinion. I'm sure you can find doctors who would disagree with me. Here is one, and I am bringing this one up because there are attributes of ketamine that can have antidepressant effects. However, the issues with ketamine remain to this day pretty significant. Here is a link to an article that will give you information about it. And ketamine has been tested quite a bit in like rodents. Mouse studies were among the first to really start examining ketamine as an antidepressant. And ketamine is now being used as one of the sedating or anesthesia part of a cocktail, if you will, for certain patients in the hospital. Okay, there are good things about ketamine, but it has, as I said before, some pretty incredibly difficult side effects and potential consequences that you wouldn't necessarily want. They have found that in some cases, the antidepressant effects of a single dose of ketamine can last for a week or longer. In other cases, it can actually increase anxiety to unbearable levels. But the downside, the real downside, it has reliably been shown that ketamine has dissociative, in other words, dissociate, hallucinations, delusions, you're not part of yourself effects. It's a euphoric of properties. Well, that sounds great. Okay. Oh man, I'm euphoric. I'm so happy I'm euphoric. This euphoria is not how you would want to be experiencing life mentally if you are out there having to perform in any, way, predictably, and addictive properties. The addictive properties are extremely high. So it's like, oh, wow, can lift depression. And I know of individuals, of course, I never name names, but I know of cases where even from being given this in a hospital for sedation reasons, that patient experienced horrible hallucinations while seemingly under, and could recall those, and has had recurrent issues since. So again, it has its usefulness in the right times, places, and doses. However, it also has many potential detrimental effects. So to move on a little bit here, I know I've belabored that point a bit, but it's so important to know these things because so often we're kind of at the mercy of people, of the medical community. We don't know, and choices are being made for us. And I just feel the more informed we can be, the better for us. And then we can be an advocate, not only for ourselves, but for others that we care about. Anyway, its antidepressant effects have been shown to be due to one of its metabolites in those mouse studies. The effect of this is even greater in female mice. And it's been thought that its effects are due to blocking NMDA glutamate receptors. Remember glutamate? Glutamate, excitatory. Oh, no, I'm not so excited because receptors have been blocked. Human trials, however, did not show the same robust and sustained antidepressant effects. Let me repeat that because this is important. All of this depression and everything that they're touting as being relieved by ketamine was mostly shown in rodents and has not been documented as nearly as well in human studies. The mere metabolite, I put it here, 2R6RHNK, seems to activate AMPA receptors rather than blocking NMDA receptors. So this metabolite, if we could somehow begin to craft that particular type of molecule, it lacks the addictive properties of ketamine. I honestly am not sure how many of those other properties of ketamine that have been demonstrated are not present when using this mirror metabolite, but I know it's not, the mirror metabolite is not as addictive. So I put down here what I think is obvious. We want to develop all kinds of treatments. It would be awesome if somehow we didn't need pharmacological treatments. However, at this point in time, we need more pharmacological treatments for clinical depression, which is an incredibly debilitating disorder. And we need some that are safer, but still effective. And here is another link about a new era of approving different kinds of drugs, pharmaceuticals, and how it's very likely that there are going to be more coming soon. The one thing we need to know and to remember is that we don't want these too soon. We do not, in my opinion anyway, want to rush any of these pharmaceuticals until they're thoroughly checked out, because that is just, that can lead to more difficulty, more problems than success stories. I have coming up overviews of hypotheses, which is a section that is very meaty, if you will. And I would like to do that in a part 3, even though this part 1 and part 2 aren't very long. Either one was a 75-minute video. But I'm trying to piece this entire, depression material into little blocks that are, I think, easier to absorb, I hope. And the overviews of hypotheses is definitely kind of its own section. It naturally happens, and it depends on you knowing what previously was covered in 1 and 2 to understand much about the hypotheses. So that being said, I am going to stop this share for a minute. And so much appreciate your really watching these, suffering through some of them, I'm sure. Do my best, and it is as close to a classroom type of lecture as it can be without you. And every single one of these would have been way better with you, with me. So this is the end of part 2, and I will be working on part 3, overviews of hypotheses. Soon. This computer has got to go. Maybe I'll start a GoFundMe page.